Okay na.
Before we can start this case presentation, may I invite everybody to please bow down your heads and feel the presence of the Lord. In the name of the Father, and of the Son, and of the Holy Spirit, amen. We praise and glorify your name. We trust and believe in you. We love you very much, our dear God. Thank you so much, Lord Jesus Christ, most especially for the gift of life you've given us. This chance and opportunity, Father God, to be able to see how beautiful the world is and to experience your love. May you always be there, Lord Jesus Christ, to guide us all the way through. Thank you also for all the knowledge, the wisdom, and perseverance you've given us. May we able to use them well, Father God, so that we may be able to inspire other people, Lord Jesus. Thank you so much, Lord Jesus Christ, for this opportunity, Father God, to study in this institution. I hope, Lord Jesus Christ, that we may use this talents that you have given us, Lord Jesus Christ, in a good way, Lord Jesus Christ. Thank you also to our clinical instructor, Sir John Vincent Lacueta, for all the knowledge and wisdom he has imparted to us. May you bless each and of each family members, Lord Jesus Christ, for they are the source of our strength and the wind beneath our wings. May this case inspire us to become worldly competitive successes in the future. This we ask in Jesus' mighty name we pray, amen. In the name of the Father, and of the Son, and of the Holy Spirit, amen. Good day, everyone. I am Erold John Salavia Estandarte, and it is my honor to present to you our case study on a patient with upper gastrointestinal bleeding related to esophageal varices secondary to liver cirrhosis. And here are my group mates. We have Sheinmae F. Enrera, J. Anthony Chua, Frennie Diane Alagenio, Asdillo, Christine Lazaga, and Winland Sydney. And for introduction, it will be reported by Frennie Diane Alagenio.
Now let's proceed with the introduction. Gastrointestinal bleeding can range in severity from minor to life-threatening. It is a common cause of hospitalization and consultation among surgeons, with an annual incidence of 100 cases per 100,000 people. The esophagus, stomach, and/or duodenum can all be affected by upper GI hemorrhage. These structures contain an abundant circulatory supply that, if disturbed, can result in life-threatening bleeding. From a study conducted by Lebrecht stated that individuals with alcoholic cirrhosis, gastrointestinal bleeding has become a common complication. Ruptured esophageal or gastric varices, as well as acute gastric erosions, were among the most common causes of bleeding. Out of the 100 patients, 53 of which suffered from an episode of gastrointestinal bleeding. The danger of gastrointestinal bleeding was evaluated based on the frequency of upper digestive tract hemorrhage as the initial clinical manifestation of cirrhosis and the incidence of bleeding within the first year after being diagnosed with liver disease. Alcoholism and malnutrition were identified to be the major risk factor in the development of cirrhosis, with heavy alcohol consumption being the leading cause of cirrhosis. A study done by Degrady A. showed a group of chronic alcoholic patients with severe and extensive esophageal varices who stopped drinking was compared to a group of patients who continued such a habit. 80% of patients who stopped drinking and had a significant decrease in the size and extent of their esophageal varices, whereas 65% of those who continued to drink had progressive expansion of their varices. In addition, the group that withdrew from the drinking habit had a substantial reduction in hepatomegaly, no return of ascites, and a significant improvement in total bilirubin level and albumin globulin ratio, whereas the group who continued drinking had a further worsening in these parameters.
So for the clinical data, biographical data, so our patient's name is patient DE. He is 55 years old, male, was born on September 17, 1966 in Texas, USA. He is currently living in La Libertad, Negros Oriental, a Filipino-American. His occupation is clerk of court, married, a graduate of business administration. He is Roman Catholic. His insurance is PhilHealth, and his attending physician is Dr. Dimaano. Next slide, please. Chief complaint: sudden onset of hematemesis 6 times around 125 ml each time over 3 hours and defecates black tarry stools for around a week now. Current health status: so patient DE, 55 years old male, married with 2 children. He arrived in the hospital tachycardic at 110 bpm with a blood pressure of 90/50 millimeter mercury, requiring immediate fluid resuscitation. He was given prophylactic antibiotic therapy. Capillary glucose levels and a serum electrolyte assay are both found to be within normal ranges. Upon assessment, he is disoriented to time and place with slurring of speech and no motor affection. Patient has a 14/15 Glasgow coma score. His vital signs are BP 100/70, respiratory rate 24 cycles per minute, temperature 37 Celsius, lungs reduce breath sounds and dullness to percussion in the right base, no heart abnormalities, JVP is not elevated, flapping tremors and fetor hepatic pulse present, and bilateral peeping ankle edema is also present. Past health history. Patient has no previous history of hematemesis, abdominal pain, fever, diarrhea, or anorexia, neither has he had recent weight loss. He was diagnosed with hepatitis C 10 years ago, which was believed to be secondary to blood transfusion following an automobile accident. He defaulted on follow-up soon afterwards and did not undergo antiviral treatment. He stopped drinking around the same time and even before this only drinks socially. History of present illness. Patient has been experiencing a sudden onset of hematemesis. He vomited bright red blood 6 times over the past 3 hours, around one-half of cup in volume. He has been passing black tarry stools for around a week now. Childhood illness. He had mumps when he was 6 years old but did not seek or consult with physician. No medications taken, only drank plenty of fluids and ate soft foods that are easy to chew. Hospitalization and injuries. He was hospitalized from an automobile accident 10 years ago. Next slide, please. Serious chronic illness. So our patient is diagnosed with hepatitis C, believed to be acquired from blood transfusion for an automobile accident that happened 10 years ago. The patient claimed that he had full immunization but did not specify the dates. Allergies, none. Medication has not been taking maintenance medications. No recent travel anywhere else outside Negros Oriental due to pandemic. Next slide, please. For the genogram, let's start first with the patient's mother side. So his grandmother has heart failure, his grandfather has diabetes, his mom has diabetes as well. Then for his father's side, his grandfather has hypertension, his grandmother has no illness, she died due to an old age. His father has arthritis, still alive, 89 years old. His older brother has diabetes, 60 years old. His older sister has hypertension, 58 years old. The patient is 55 years old, the youngest among the three. He has hepatitis C and esophageal varices. His wife has no illness, is 54 years old. They have two children. The, uh, the eldest is a female, no illness, as well as the youngest, which is male. Next slide, please. For growth and development, generativity versus stagnation is the seventh of eight stages of Erik Erikson's theory of psychosocial development. This stage takes place during the middle adulthood between the ages of approximately 40 and 65. So during this time, adults strive to create or nurture things that will outlast them, often by parenting children or contributing to positive changes that benefit other people. Contributing to society and doing things to benefit future generations are important needs of generativity versus stagnation stage of development. Generativity refers to making your mark on the world by caring for others as well as creating and accomplishing things that make the world a better place. Key characteristics include making commitments to other people, developing relationships, mentoring others, contributing to the next generation, and those who are successful during this phase will feel that they are contributing to the world by being active in their home and community. Next slide. So for stagnation, this refers to failure to find a way to contribute. These individuals may feel disconnected or uninvolved with their community and with society as a whole. Some characteristics of stagnation include being self-centered, failing to get involved with others, not taking an interest in productivity, no efforts to improve the self, placing one's concern above all else, and those who fail to attain this skill will feel unproductive and uninvolved in the world. The patient feels angry at himself for being weak. He sees his hospitalization as very stressful for him and his family. However, he remained hopeful despite his disease because he always felt their support. Despite this, the patient is in state of stagnation due to limitations imposed on him because of his disease. Next slide, please. So for the overview of anatomy and physiology, Frennie will be the one to report that.
Now let's move on to the overview of anatomy and physiology. For the digestive system, it is the duty of the digestive system, which stretches from the mouth to the anus to receive food, break it down into nutrients, which is a process called digestion, absorb the nutrients into the bloodstream, and extract from the body the indigestible parts of food. Now, for the upper GI tract, first is the mouth. The mouth, when eating, food continues to pass into the GI tract. The tongue forces the food into the mouth as a person swallows. To avoid choking, a thin flap of tissue called the epiglottis folds over the windpipe and the food passes through the esophagus. Now for the throat and esophagus. The mechanism becomes automatic once a person starts swallowing. The brain activates the esophagus muscles and peristalsis because a ring-like muscle called the lower esophageal sphincter relaxes as food enters the end of the esophagus and enables food to pass through the stomach. In order to prevent the stomach from flowing into the esophagus, this sphincter normally remains closed. For the stomach, After the food reaches the stomach muscles combine the food and the liquid with the digestive juice. The stomach slowly empties its contents into the small intestine called chyme. For the duodenum, the initial section of the small intestine is the duodenum. It is situated between the stomach and the jejunum, the middle section of the small intestine. Food travels into the duodenum after mixing with stomach acid, where they combine with the bile from the gallbladder and digestive fluids from the pancreas. Next slide, please. Now let's move on to the anatomy of the hepatic system. The liver weighs approximately 1.3 to 1.8 kilograms. Liver extends up under the ribs and is 4 to 8 centimeters in height at the mid-sternal line and 6 to 12 centimeters in height at the mid-clavicular line. The liver is served by two separate blood supplies. First is the portal vein. It is 75% of the blood flow to the liver through the portal vein. It carries nutrient-rich blood from the stomach and intestines. Now for the hepatic artery, the remaining 25% of the blood flow is through the hepatic artery. It carries oxygenated blood from the lungs to the hepatic cells. Liver lobule are the functional unit of the liver. Kupffer cells are the phagocytic cells of the reticuloendothelial system. Lastly, hepatocytes are single cell cells that regenerate on demand. Next slide, please. For the physiology of the hepatic system, first, carbohydrates. The liver extracts glucose, fructose, and galactose from the blood. These simple sugars are metabolized into glycogen to replenish liver stores. Liver helps maintain a normal blood glucose level, preventing hyperglycemia and hypoglycemia. For the proteins, it provides needed amino acids through transamination. The only source of major plasma and albumin, which is necessary for the maintenance of a normal internal environment and for the fluid and electrolyte balance. Liver is also a source of several clotting factors. It produces bile, which is one of the major function of the liver. Bile salts are necessary for the absorption of fats, cholesterol, and fat-soluble vitamins. Liver also has bilirubin as a byproduct of the hem portion of RBCs and is released when these cells are destroyed. Liver is also a storage of minerals and vitamins such as A, D, B2, K, and copper. It is also a blood reservoir. Next slide, please. Now let's move on to the discussion of the disease condition. What are esophageal varices? Esophageal varices are swollen or dilated veins on the esophageal lining. When normal blood flow to the liver is impeded by a clot or scar tissue, esophageal varices occur. Blood travels into tiny blood arteries that aren't intended to carry huge amounts of blood to flow around the obstructions. Blood can leak or even burst from the vessels, producing life-threatening hemorrhage. For the clinical manifestations of bleeding esophageal varices, which includes vomiting large amounts of blood, black tarry or bloody stools, lightheadedness, and loss of consciousness in severe cases. Next slide, please. What is liver cirrhosis? So liver cirrhosis is a chronic disease of the liver characterized by diffuse inflammation and fibrosis. Cirrhosis can occur in any age. Alcoholism and malnutrition are the two major risk factors of cirrhosis. Cirrhosis develops portal hypertension, which can result in ascites and esophageal varices. Other complications include portal systemic encephalopathy or PSE. For the clinical manifestations of cirrhosis, these are nausea, vomiting, anorexia, indigestion, flatulence, constipation, weight loss, malnutrition, abdominal pain for the late signs, ascites, jaundice, edema, anemia, and bleeding. Next slide, please. Now let's move on to the pathophysiology.
Okay, so now let's discuss the pathophysiology. So we have here the diagram that shows the pathology beginning with the risk factors. So here, for the risk factors based on the assessment of the patient, patient has history of hepatitis C infection, and the patient has also history of alcoholism. So these risk factors contribute to the development of liver cirrhosis. So this is manifested by the patient based on the abdominal ultrasound. So sunken cirrhotic liver with heterogeneous echo texture, irregular edges, and surface nodularities. So the laboratory results of the patient also shows in the liver profile that there is a decrease in liver enzymes, which are AST, ALT, the bilirubin, and INR, which are also a symptom or signs of liver cirrhosis. So going down, um, because of the liver cirrhosis, the scar tissue will compress on the blood vessels through the liver. Because of this compression, the blood vessels or the portal vein in the liver will be narrowed. So let's first go to follow the last arrow. So if there is a narrowing of the blood vessel in the liver or the portal vein, it will enable the fluid in the blood to get through the liver and it will cause it to back up into the and based on the abdominal ultrasound of the patient, it shows dilated skin with inside limits. The blood will also back up, which can cause splenomegaly. It's also manifested by the patient reporting increased abdominal sound. If there is splenomegaly, it can cause hypertension or overactive kidney. We all know that it can help in filtering all and damage cells. There is overactive kidney, cause an increased rate of rate of NRD cell strength. And this manifested in the laboratory results of the patient when you can see there is spinal bleeding, and count. Now let's go to the right arrow. So there is a narrowed blood vessel or portal vein in the liver. The blood will start to be diverted away from the liver because of the high pressure. This is called a portal vein. If this happens, there will be decreased blood flow supply in the liver. And if there is a decreased blood supply in the liver, there will also be decreased liver function. We all know that one of the functions of the liver is detoxification of the blood. Um, let's first look at the arrows mentioned at the top. If there's a decreased liver function, toxins like sulfur will stay in the blood and go to the lungs. The liver cannot detoxify the blood if the toxin will stay in the blood and will travel in the whole system. So it can toxin can go into the lungs. If it reaches the lungs, the traces of this toxin like dust and smell stays up in the blood and it will cause proper hepatitis, which is um, manifested by the treatment according to the assessment. Now, going to the arrows going down, decreased liver function again will cause decreased detoxification and removal of ammonia from the blood. So, that is also one function of the liver, removing ammonia from the blood. If the liver cannot do function well, these toxins like ammonia can get into the brain and it can cause atherosclerosis or static tremor, which is manifested by vision. It can cause hepatic encephalopathy and hypertension, disorientation, and and one of the functions of the liver also is production of albumin. If there is increased liver function, it will inhibit the production of albumin, which is manifested by the patient and the liver profile in the laboratory results wherein the albumin is very low range. So, if there is a decrease in albumin production, there will also be a decrease next slide. If there's a decrease in the production of albumin, it can cause decrease in colloid osmotic pressure. If there's a decrease in colloid osmotic pressure, fluid from the blood vessels will escape into the kidney. So this can cause edema, and in the case of the patient is manifesting bilateral and ankle edema. Also, if the fluid escapes um, out of the blood vessels, it can cause and going back to um, the narrowing of the portal vein or the blood vessel of the liver, it can cause increased pressure in the portal vein. So if there is an increased pressure in the portal vein due to the production of the scars, the fluid inside the blood vessels will be pushed out across the vein. You can see this like in the abdominal curve. And this is excess of fluid in the abdominal curtain, which can result as sepsis. So this is manifested in the abdominal ultrasound of the patient where there is abdominal fluid present, which suggests ascites. Going back, because of the increased pressure in the pelvis, it will result to portal hypertension, where the abdominal ultrasound of the patient where it is diluted portal. So for hypertension can lead to high pressure that will prevent the blood from entering the uterus, and it will push it to smaller blood vessels like the blood vessels in the esophagus. So these blood vessels are thin and close, and they are not made or designed to carry large loads of blood. So the extra blood causes it to expand and swell. If these blood vessels and the blood vessels start and well, but it will result in fatal varices. So when the pressure caused by the extra blood gets too high, the varices can break over in a quantity, or the blood vessels break because it may lead to upper and symptoms of upper bleeding are hematomesis or vomiting, with blood, and the pancreas block carries fluid, and also cause cardiac and hypotension and decrease in the hematopoiesis and production of the so that's all now on to the medical.
So let's move forward to the medical and nursing management for esophageal varices. For medical management, next slide please. This includes prevention. So The patient should be screened endoscopy repeated every 2 to 3 years. Pharmacological therapy includes beta blockers such as propranolol and nadolol to reduce portal pressure and prevent episodes of bleeding. Nitrates for patients if they did not respond to beta blockers. Vasopressin is also given to lower portal pressure by causing splanchnic vasoconstriction to control esophageal bleeding. Propranolol, a beta-adrenergic agent, also reduces portal pressure. Octreotide decreases splanchnic flow and portal pressure, which mimics the action of hormone somatostatin. Endoscopic sclerotherapy is a first treatment for active esophageal bleeding. The agent causes thrombosis and sclerosis of the vessel and should result in hemostasis in 3 to 5 minutes. Balloon tamponade, on the other hand, is used if preceding methods do not control bleeding, a procedure in which a balloon is inflated within the esophagus or stomach to apply pressure on the bleeding blood vessel, compressing the vessels and stop the bleeding. Next slide, please. Transjugular intrahepatic portosystemic shunt. This is a procedure in which the surgeon creates a shunt between the hepatic and portal veins, which decompresses the portal system and reduces hypertension enough to control active bleeding in most patients. Surgical shunt. This is to shunt blood away from the portal circulation. This is one of the last measures used to treat esophageal varices. This causes the accumulation of toxins in blood since ammonia is no longer metabolized in the liver. Patient will be at risk for portal systemic encephalopathy. For next slide, please. For nursing management, it is important for us to assess symptoms like ecchymosis, epistaxis, fatigue, and bleeding gums. Monitor level of consciousness, vital signs, and urinary output to evaluate fluid balance. Monitor the client during blood transfusion administration if prescribed. Institute measure to address bleeding. Use a small gauge needles and apply pressure or cold for bleeding. Provide nursing care for patient undergoing a prescribed balloon tamponade to control bleeding. So we have to explain the procedure to the client to reduce fear and enhance cooperation with insertion and maintenance of the esophageal tamponade tube. You also have to monitor the patient closely to prevent accidental removal or displacement of the tube with resultant airway obstruction. Providing a nursing intervention for client undergoing eye saline lavage. This ensures nasogastric tube patency to prevent aspiration, observe gastric aspirate for evidence of bleeding, protect the client from chilling. After injection sclerotherapy, assess for aspiration, esophageal perforation, and continued bleeding. After portal systemic surgical intervention, monitor for complications such as systemic encephalopathy, liver failure, and continued bleeding, and also administer prescribed medications, which may include vasopressin and vitamin K to reduce bleeding. Now let's proceed to the diagnostic and laboratory tests for esophageal varices. So this includes ultrasound, the whole abdomen. The diagnosis includes liver cirrhosis, splenomegaly, and moderate ascites. So liver is shrunken, cirrhotic, and with heterogeneous ecotexture and irregular edge and surface nodularity. There is no focal hepatic lesions present. The portal vein is dilated to 15.5 millimeter, while the splenic vein is dilated to 13.5 millimeter, with multiple collaterals, splenomegaly obscuring the left kidney with a span of 20 centimeters. The abdominal free fluid is present, suggestive of moderate ascites. So the first ultrasound image shows a cirrhotic liver, and this is characterized by diffuse inflammation and fibrosis resulting in significant loss of liver function. The second image represents the scarring of the portal vessels. So the increased pressure can force fluid into the abdominal cavity, resulting in ascites. It is the third picture. Then the second picture is the scarring of the liver causes the blockage of blood flow to the organ, causing portal hypertension. As a result, the spleen becomes engorged with blood, leading to splenomegaly. Next slide, please. So for the complete blood count, the white blood cell is normal. The hemoglobin is below the normal value, only 5 gram per dl. The low hemoglobin indicates low oxygen carrying capacity of the blood due to excessive blood loss. The hematocrit is also below the normal value, which is 18%. So this indicates too few RBC, which results to anemia because of the upper GI bleeding. Platelet is also decreased at 80,000 millimeters cubed. Low platelet count indicates decreased coagulation because of inadequate production of hormone thrombopoietin in the damaged liver. Next slide, please. For the liver panel, the aspartate aminotransferase is above the normal value, which is 70 U per liter. Elevated EST goes to the bloodstream once liver cells becomes damaged. This indicates liver problems. The alanine aminotransferase is also above the normal value, so this indicates damage in liver cells as well. The total bilirubin is above the normal value, which is 6 milligrams per dl, and this indicates liver damage, which causes distorted portal blood flow, resulting in decreased hepatic clearance of bilirubin. The albumin is below the normal value. There is a uh, total of 2 grams per dl, and this indicates liver problem caused by decreased synthesization by hepatocytes and water and sodium retention. International normalized ratio is above the normal value, which is 1.6, and this indicates decreased capacity of the liver to make blood clot due to reduction in bile production, which absorbs vitamin K. So that's it for laboratory and diagnostic procedure for um, esophageal varices secondary to cirrhosis. Next slide, please. So for the drug study, the first medication is vasopressin. Brand name is Tetrasin, and it's an antidiuretic drug. Route or dose IV infusion, initially 0.2 to zero point 0.4 unit per minute, progressively increased to 0.8 units per minute. It increases reabsorption of water by renal tubules, and it directly stimulates smooth muscle in the GI tract. So it is used to treat acute massive GI hemorrhage, or what we call as the esophageal varices, and it is used as treatment of pulseless arrest, ventricular fibrillation or tachycardia, and vasodilatory shock with hypotension unresponsive to fluids or exogenous catecholamines. Next slide, please. For contraindications, it is contraindicated to patients with headache, hypertension, coronary artery disease, heart failure, asthma, accumulation of toxins, and seizure. Side effects include slow heartbeats, pale skin, numbness in your fingers or toes, stomach pain, nausea, vomiting, dizziness, headaches, sweating, and rust. Next slide, please. For the patient's teaching or nursing intervention, so baseline assessment includes established baselines for weight, blood pressure, pulse, serum electrolytes, hemoglobin, hematocrit, and urine-specific gravity. Intervention includes monitor input and output closely, weigh the patient daily as well, monitor serum electrolytes, hemoglobin, hematocrit, and urine-specific gravity, evaluate the injection site for erythema, pain, and abscess because this can indicate infection. Report side effects to physician or dose reduction. Be alert to early signs of water intoxication, which includes drowsiness, listlessness, and headache. Observe evidence of GI bleeding, chest pain, and allergic symptoms. Promptly report headache, chest pain, shortness of breath, and other symptoms. Stress importance of intake and output, and it's very important to tell our patient to avoid alcohol. Next slide, please. The next drug would be the propranolol. Its brand name is Enrera and it's a beta-adrenergic blocker. It is administered per orum 20 mg PID. It reduces portal pressure through the reduction of portal and collateral blood flow. It competes with adrenergic neurotransmitters at sympathetic receptor sites, and it is used to treat angina pectoris, arrhythmias, essential tremors, hypertension, hypertrophic subaortic stenosis, migraine headache, pheochromocytoma, and prevention of myocardial infarction. Next slide, please. So it is contraindicated to asthma, bradycardia, cardiogenic shock, heart block, Raynaud's syndrome, and compensated CHF or congestive heart failure. So side effects are the usual side effects of drugs that are beta-adrenergic drugs. So let's skip that. Let's next slide, please. So for nursing intervention, we have to assess baseline or renal hepatic function test, assess for vital signs as well, assess pulse for quality, irregular rate, bradycardia, monitor EKG for cardiac arrhythmias, assess fingers for color and numbness. This could indicate Raynaud's syndrome. Assess for evidence of congested heart failure, monitor input and output, assess for rush, fatigue, and behavioral changes. Therapeutic response ranges from a few days to several weeks. Measure blood pressure near the end of dosing interval. Next slide, please. For patient or family teaching, do not abruptly discontinue medication. Compliance with therapy regimen is essential to control hypertension, arrhythmia, and anginal pain. To avoid hypotensive effect, rise slowly from lying to sitting position. Wait momentarily before standing. Avoid tasks that require alertness, motor skills until response to drug is established. Report excessively slow pulse rate, peripheral numbness, and dizziness. Do not use nasal decongestion, over-the-counter cold preparations without physician's approval, and restrict salt alcohol intake. Next slide, please. The third drug is octreotide. It's sandostatin, the brand name. Its classification is somatostatin analog, and it's given bolus of 25 to 50 microgram followed by IV infusion of 25 to 50 microgram per hour for 48 hours. So it suppresses secretion of serotonin, gastroenteropancreatic peptides, and it enhances fluid and electrolyte absorption from GI tract. So it is used to control esophageal varices, treatment of AIDS associated secretory diarrhea, chemotherapy-induced diarrhea, insulinomas, small bowel fistulas, Zollinger-Ellison syndrome, Cushing syndrome, hypothalamic obesity, malignant bowel obstruction, and post-gastrectomy dumping syndrome. Next slide, please. So the complications includes contraindications is those patients who are diabetic with gastroparesis, renal failure, hepatic impairment, heart failure, and concomitant medications altering heart rate or rhythm. Next slide, please. Patient teaching. So we have uh, first baseline assessment is we have to assess for or we have to establish baseline blood pressure, weight, thyroid function, serum glucose, and electrolytes. Monitor serum glucose, thyroid function tests, and fluid electrolyte balance. In acromegaly, monitor growth hormone levels. Monitor BP, pulse, respirations periodically during treatment. Be alert for decreased urinary output and peripheral edema. monitor daily pattern of bowel activities to consistency, and therapy should provide significant improvement of severe watery diarrhea. And the last drug would be, next slide please, Nadolol. This is brand name is CoreGuard. It's a beta-adrenergic blocker, and it is initially given at 40 mg per day (PO). It may increase to 40 to 80 milligrams at 3 to 7 days intervals. So it competitively blocks beta-1 adrenergic receptors located in the heart and vascular muscle, inhibiting the actions of epinephrine and norepinephrine, and producing negative inotropic and chronotropic effects. So it is used to manage mild to moderate hypertension, used alone or in combination with diuretics, especially thiazide type. Next slide, please. So it is contraindicated to patients with bronchial asthma, cardiogenic shock, sinus node dysfunction, second or third degree heart block, sinus bradycardia, and uncontrolled cardiac failure. So side effects are posted on the screen. Next slide, please. For patient or nursing intervention, we have to assess first baseline renal or hepatic function test, assess for BP, mga vital signs, monitor the vital signs, assess pulse for quality, irregular rate, bradycardia, assess hands for coldness, tingling, and numbness, assess evidence for chronic heart failure or congestive heart failure, like symptoms like dyspnea, night cough, peripheral edema, and distended neck veins. Also monitor input and output. Do not discontinue abruptly. You have to instruct the patient that. Inform physician if difficulty breathing, night cough, swelling of arms, dizziness, confusion, depression, rush, fever, or sore throat, and unusual bleeding or bruising occurs. Also, tell your patient to avoid tasks that require alertness, motor skills, until response to drug is established, and limit the use of alcohol or avoid alcohol. Now let's proceed with the physical assessment.
So now let's proceed for the physical assessment findings. For the general health history, patient DE is a male, 55 years old, looks ill, confused, and lethargic. His Glasgow Common Scale score 14/15. He is disoriented to time, place, and person. He is not fully responsive and speech is slurred. Vital signs, temperature 37 degrees Celsius or 98 degrees Fahrenheit. Pulse rate 100 beats per minute, strong 3D pulse. Respiration rate 24 cycles per minute, irregular with use of accessory muscles, and blood pressure is 100/70 mmHg millimeter per mercury and following resuscitation. For the skin and nails, skin is pale in color, cold and moist, jaundice skin observed, no presence of rashes or lesion observed. Skin has pore, skin turgor, skin folds return to place after 4 seconds. Nails are smooth, thick, and firm. Nails are pale on both hands. Poor capillary refill as evidenced by color not able to return after freezing in less than 2 to 3 seconds. And for the head, face, and hair findings, patient head is normocephalic and proportional to the body. Skull and face have no nodules or masses when palpated. Face appears smooth and has uniform consistency. Facial is symmetrical in features, round in shape, and has no involuntary movement observed. Temporomandibular joint is smooth, symmetrical in motion, with no pain, crepitus, or clicking. Hair strand is thin and rough, black in color with few gray hairs and slightly alopecia is present. No presence of nits, dandruffs, and lesions observed. Upon palpation, there are no deformities and masses, but a generalized headache is felt by sudden movement of the client. For the eyes, upper eyelid normally covers one half of the upper iris, eyelids in contact with the eyeball. lacrimal gland and nasolacrimal duct, no swelling, redness, or drainage. Bulbar conjunctiva is pale, smooth, and has no presence of lesions and foreign bodies. Palpebral conjunctiva is pale and smooth. Sclera is yellowish in color in both eyes, and the cornea is transparent and shiny. Pupils are black and equal size. And perla, poor visual acuity, peripheral intact, extraocular muscles are intact, eyelids are symmetrical without masses and lesions, and eyebrows are eventually distributed, no lesions and masses upon palpation. For the ears, patient ears are equal in size bilaterally. His auricles are aligned with the outer canthus of the eye. No pits, creases, or lesions. Auricles and mastoid process are non-tender. Presence of cerumen in external canal. Noted. No discharges, soft, playable, and non-tender. Tragus, non-tender also. For the nose and sinuses, patient nose is symmetric and uniform in color. No deformities. Septum is in the midline. No discharges. Nasal flaring noted. Nares are patent. Nasal mucosa is pale and dry. Frontal and maxillary sinuses are non-tender upon palpation. For the patient's mouth and teeth, lips are pale, dry, symmetrical, and slightly cracked. No unusual odor. The oral mucosa is pale. Tongue is pink in color, moist and symmetrical. Tongue and uvula are positioned in the midline. Gag reflex is intact. Has 28 sets of teeth, yellowish in color with good occlusion. Fetor hepaticus present. Papillae intact, frenulum in the midline. No ulceration, discharges, and enlargement of tonsils noted. For the neck, for the neck, trachea and thyroid gland, the patient position in the midline and non-tender for his neck, and jugular venous pressure (JVP) is not elevated. Accessory muscles sternocleidomastoid and trapezius intact. No lumps, bulges, or masses palpated. Trachea is in the midline. Thyroid gland not palpable and intact. For the heart, pulse rate is 100 beats per minute. Strong and 3D pulse. S1 is best heard at the fifth intercostal space left mid-clavicular, whereas the S2 is best heard at the second intercostal space left sternal border. For the lungs, it is symmetrical, no scar noted. Respiratory rate is 24 cycles per minute, irregular, and with the use of accessory muscles, no tenderness and masses palpated. Diminished breath sounds and dullness to percussion in the right base, and reduced chest expansion. Abdomen, it is uniform in color and bloated. Abdominal girth is 49 inches. His umbilicus is positioned in the midline. Caput medusa observed. Absent vowel sounds upon auscultation. Flank dullness on percussion noted at the upper right quadrant, and tenderness upon palpation. And for the extremities findings, patient extremities are slightly cold and pale, flapping tremors or asterixis, and fetor hepaticus observed, bilateral pitting, ankle edema is present, weakness noted, and cannot perform full range of motion. And for the neurologic exam, the mental status examination, client is confused and lethargic, disoriented to time and place, slurring of speech, no motor affectation, and his Glasgow coma score 14/15. That's all for the physical assessment findings. So now let's move on for the signs and symptoms of a patient having upper GI bleeding related to esophageal varices secondary to liver cirrhosis. So these are the common signs and symptoms of upper gastrointestinal bleeding. So patient suffering vomiting bright cold blood, bright blood. The next is dark bright red blood mixed with stool. These are the signs and symptoms. As you can see the picture, one of the common sign is black tarry stool, and also the next picture as we can see is syncope or fainting or passing out. Then next is lightheadedness, and patient also suffering dyspepsia. The next signs and symptoms, patient is suffering epigastric pain and also chest pain. The next is patient has abdominal pain and also dysphagia. The next signs and symptoms, which is common, weight loss and also jaundice. And as we can see the picture, the sclera is yellowish in color or jaundice. And next, the skin is pale or pallor, and patient has shortness of breath, and patient is feeling tired and has rapid pulse, tachycardia. Then, one of the signs and symptoms also is drop in blood pressure and also weakness. So you can see in the picture, it's below the normal range of the blood pressure. And also presence of bilateral pitting ankle edema and fetor hepaticus, as we can see in the picture. And also flapping tremors when the wrist is extended. So this is called asterexis. So that's all for the common signs and symptoms of a patient having upper GI or upper gastrointestinal bleeding related to esophageal varices secondary to liver cirrhosis. So for the next topic, for the functional health pattern will be discussed by Mr. Welvin Asdillo.
Okay, so let us now proceed to the functional health pattern. So for our health perception, health management, usual, overall health is in the past was good, performs exercises and maintains a healthy diet, no known food and drug allergies, takes multivitamins, drinks 8 glasses of water, used to drink alcohol but stopped after diagnosed with hepatitis C, over-the-counter medications and enough rest were done when experiencing cough and flu, hard had a hard time complying the doctor's prescription and nurse suggestion. So in our initial assessment, we have here he stated health group 4, sought admission, sudden onset of hematemesis and has black tarry stools during defecation, complaints of abdominal pain on the right upper quadrant and abdominal was tender upon palpation, presence of caput medusa noted, tachycardic upon arrival and has a 110 beats per minute. Complaints of difficulty in breathing with respiratory rate of 25 cycles per minute and has a blood pressure of 90 over 100. MMHG, was given prophylactic antibiotic, confused since onset, and experienced fatigue, NPO, and claimed that the nurses and other members of the healthcare team are helpful. So for the ongoing, he described health as good, vital signs, BP is 90 over 70 mmHg, respiratory rate is 20 cycles per minute, pulse rate is 95 beats per minute, and the temperature is 37 degrees Celsius. Diet is still NPO, oriented to time and place, and he claimed to have immediately complied with the doctor's prescription and nurse suggestion. So let us now proceed to the nutritional metabolic pattern. So his usual breakfast is 1 cup of coffee, snacks, and 500 ml of water. Lunch is 240 ml soft drinks, and snacks is 500 ml fruit juice. Dinner is 240 ml soft drinks, 500 ml water, supplements vitamin C every day, drinks alcohol 3 years ago, and no food restrictions, and no known food and drug allergies. So for the initial, he claimed to have no appetite due to a painful stomach, claimed to feel full easily, stopped drinking 10 years ago. He vomited bright red blood 6 times, about 125 ml, and no known food and drug allergies, jaundice on the skin, warm to touch, poor skin turgor, and has a dry lips. Also, difficulty in swallowing, redness of eyes observed, was given IV fluids and medications vasopressin, propanolol, octreotide, and nadolol. Noted to have decreased in weight from 62 kilograms to 58 kilograms upon assessment. So for the ongoing assessment, still NPO, no appetite, no known food and drug allergies, intact capillary refill, and skin turgor noted. Was still given IV fluids. So for our elimination pattern, in the usual bowel, no ambulation problems, no assistive devices. Usual daily output is 250 grams per day. Stool form brown in color, and the bladder has no problems, no assistive devices. Usual daily output is 2000 ml per day. Urine amber in color, and usual fluid intake. So for the initial bowel, in the bowel, defecates 3 times today, passing of block, starry stool, vomits blood 6 times over 3 hours, 125 ml setting. So the bladder, inserted Foley catheter, urine output is 30 ml per hour in amber in color. So for the ongoing assessment, defecates 2 times today, passing of black, star stool, bladder, inserted Foley catheter, urine output is 30 ml per hour, amber in color, and minimal sweating. So let us now proceed to the activity and exercise pattern. So for the usual, leisure activities, watching TV, and reading. Daily exercise is brisk walking for 20 minutes, experience abdominal pain sometimes when sitting or moving. So we have here the usual daily routine from 6 to 6:20 a.m. Exercise 6:20 to 7:30 a.m. Prepare for work. So in 7:30 to 8 a.m. travel time, 8 to 5 p.m. at the office, 5 to 5:30 travel time, 5:30 to 6:30 p.m. watch TV, and 6:30 to 7 p.m. dinner. 7 to 9 p.m. watch TV, read the newspaper. So from 9 p.m. sleep, and then no ambulation problems, no assistive devices, and has perceived ability for feeding, 0. Bath, bathing, 0. Toileting, 0. Bed mobility, 0. Dressing, 0. Grooming, 0. General mobility, 0. Cooking, 4. Home maintenance, 0. And shopping, 0. So here is the functional level code for level 0 full self care, level 4 use of equipment devices Level 2 is requiring assistance or supervision from another person. Level 3 requires assistance or supervision from another person or device. And the level 4 is dependent and does not participate. So for our initial assessment, as changes and alterations in daily routine and physical strength, and he verbalized, the patient verbalized Morakog Giluya Sige. And then his daily routine and physical strength is altered, has fatigue, experience abdominal pain when sitting or moving, and then no exercise performed today. The patient is lying on bed, verbalized akas ko ginhawa usahay. For the ongoing assessment, has changes and alterations in daily routine and physical strength. His daily routine and physical strength is altered, his fatigue is lessened, experience abdominal pain when sitting or moving, no exercise performed today, and the patient is lying on bed. So let us now proceed to the sleep rest pattern. So for the usual, patient usually sleeps at 9 p.m. and awakening hour is 5:30 a.m. There is no sleep interruptions, and the number of hours of sleep is 7.5 hours, and sleep aids none, and has no sleeping problems. So for our initial assessment, um, he sleeps at around 9 p.m. and wakes up at 5:30 a.m. Um, there is a sleep interruptions due to the nurse's procedures like vital signs taking, awakens at times when he vomits blood or experience abdominal pain. Number of hours of sleep is 6 hours, and no sleeping aids, sleep problems, occasional awakening due to the nurse procedures like vital signs taking. So for the ongoing assessment, the patient sleeps at 10 p.m. and awakes at 7:30 a.m. and there is a sleep interruption due to the nurse procedure like vital signs taking awakens. And the number of hours of sleep is 9 hours and 30 minutes, and no sleeping aids, and there is an occasional awakening due to the nurse procedures like vital signs taking. Next here is we have cognitive perceptual pattern. So for the usual, the patient graduated political science, licensed lawyer, has good decision-making skills and wise, oriented to time, person, and place, and no hearing problems, claimed to be forgetful sometimes, especially when drunk. Language spoken is English, Bisaya, and Tagalog. No sensory perception deficit, finds it easy to learn regardless of teaching method used. So for our initial, confused since onset of symptoms, no hearing problems, slurred of speech, complaints of sudden onset of hematemesis and has black tarry stools during defecation, has been complaining of abdominal pain on the right upper quadrant, and he rates pain as 6, 1 as the lowest and 10 as the highest. So for our ongoing assessment, the patient is already oriented to time and place, and he rates pain as 3. So next is the self-perception, self-concept pattern. So here we have here the usual that he described himself as a loving husband and a protective and caring father, gets mad when his children are about to obey him, contented and happy with his life together with his child and grandchild. Has good sense of well-being. He was hospitalized due to an automobile accident 10 years ago, and he got hepatitis C because of blood transfusion. So for the initial, he feels angry at self for being weak and succumbing to his disease. Feels that his hospitalization is very stressful, and he claims to be bored, anxious about his situation. So for our ongoing assessment, feel less anxious because he has been given treatment for his concern. He believes that his hospitalization is stressful and he claims to be bored in the hospital. Next is role relationship pattern. So for our usual, he was living with his wife and two children, has a strong bond with his whole family, good relationship with neighbors, financially stable to meet needs. Here the familial disease is hypertension. For our initial assessment, the client decides on his own with the guidance of his children, cared by wife in the hospital. His wife feels that his hospitalization is important so he can go back to her previous level of functioning. Relatives visit him. For our ongoing, his wife is always at her bedside, ready to attend to his needs. Still, his wife feels that his hospitalization is important so he can go back to her to his previous level of functioning. Relatives frequently drop by to visit her. So, for our coping stress managing pattern, for our usual, he copes up with stress by watching TV and reading books, talks to her wife when problems arise, and drinks alcohol to cope with problems. For our initial, irritated sometimes but manages it well, client states that being in the hospital is stressful. And for our ongoing assessment, irritated sometimes because of his visitor's noise, and he verbalized that being in the hospital is stressful. So for our values belief pattern, for our usual, so the patient's religion is a Roman Catholic and turns to his wife when he needs help with anything, does not believe in superstitious beliefs, he always prays to God, he always attends to Mass, reads the Bible, and do the Rosary. So for our initial, he considers himself as considers good health as most important to him and hopeful despite the disease, and he is reading a Bible today. For our ongoing assessment considers good health as most important to him and hopeful despite the disease, and he is reading a Bible. So for our sexually reproductive pattern, for the usual, patient is not sexually active, a separate room with his wife, and circumcises often. For our initial, do not engage in any sexual activities, and for our ongoing, do not engage in sexual activities. So let us now proceed to our nursing care plan. So we have identified three priority nursing diagnoses. So first here is So again, we have identified three priority nursing diagnoses. So first we have here is the diagnosis of fluid volume deficit related to blood volume loss secondary to upper GI bleeding as evidenced by hematemesis or vomiting of blood. So for our assessment, for our subjective data, the patient verbalized. I vomited blood 6 times already and I defecated a black tarry stools for around a week. So for our objective data, hematemesis 6 times around 125 ml each time over 3 hours, defecates black tarry stools for around a week, skin pallor, and vital signs for the blood pressure is 90 over 50 mmHg. Heart rate is heart rate is 110 beats per minute. Respiratory rate is 24 cycles per minute and has a temperature of 37 degrees Celsius. So the laboratory results in the complete complete blood count test, hemoglobin is 5 g per dl, hematocrit is 18%, and the platelet is 80,000 per cubic millimeter. So for our planning, after 8 hours of nursing intervention, the patient will have an absence of upper GI bleeding, a hemoglobin level over 13, blood pressure within normal range, alert and oriented, and normal skin color. So for our nursing interventions, we have here first assess vital signs, particularly blood pressure level. This is because hypovolemia due to GI bleeding may lower blood pressure levels and put the patient at risk for hypotensive episodes that lead to shock. Next here is Commerce a fluid balance chart monitoring the input and output of the patient. Include also the episodes of vomiting, gastric suctioning, and other gastric losses in the input-output charting. This is to monitor the patient's fluid volume accurately. Next intervention is start intravenous therapy as prescribed. Electrolytes may need to be replaced intravenously and encourage oral fluid intake of at least 2,000 ml per day if not contraindicated. This is to replenish the fluids and electrolytes lost from vomiting or other gastric losses and to promote better blood circulation around the body. So next intervention is to educate the patient or guardian on how to fill out the fluid balance. This is to help the patient or the guardian take ownership of the patient's care, encouraging them to drink more fluids as needed or report any changes to the nursing team. Next is administer blood transfusion as prescribed. This is to increase the hemoglobin level and treat anemia, and hypovolemia related to GI bleeding. So for our evaluation, at the end of 8 hours nursing intervention, goals are met as evidenced by no signs of bleeding such as vomiting of blood, black or tarry stool, and presence of skin pallor. Hemoglobin level is within normal range from 13.5 to 17.5 G per DL and has a normal blood pressure between 120 over 80 mmHg to 90 over 60 mmHg and alert and oriented as evidenced by orientation of place and time. Lastly, good skin complexion and no abnormal skin color such as skin pallor.
And for our second nursing diagnosis or nursing care plan for the diagnosis, it's ineffective tissue perfusion related to insufficient blood flow or interruption in blood flow to organs and tissues and deficient amount of hemoglobin to transport oxygen or blood loss. For the assessment, for the subjective has changes and alterations in the routine and physical strength that verbalizes mura kugi luyasigi as patient opted. Patient also reported difficulty in breathing, magpasko ginhawa usahay as he verbalized. For the objective, patient's vital signs, blood pressure of 90 over 50 millimeter mercury, respiration rate of 25 cycles per minute, pulse rate of 110 beats per minute, and temperature of 37 degrees Celsius. Patient also tachycardic upon arrival with 110 beats per minute. Jaundice on the skin noted, warm to touch, poor skin turgor, and has dry lips. Redness of eyes also noted. For the patient care planning, also observed cool skin during assessment. For short goals, for planned objectives at the end of 8 hours of thorough nursing care and interventions, the patient will. Patient identifies factors and improves circulation. Patient identifies necessary lifestyle changes. Patient exhibits growing tolerance to activity. Patient shows no further worsening or repetition of deficits. Patient engages in behaviors or actions to improve tissue perfusion. Patient maintains maximum tissue perfusion to vital organs as evidenced warm and dry skin. Patient present and present strong peripheral pulses, vital signs within patient's normal range, balance, I and O, absence edema, normal ABGs, alert LOCs, and absence of chest pain. Patient also is expected to vocalize or demonstrate normal sensations and movements as appropriate. And lastly, patient states when to contact physician or healthcare professional as needed. And for our intervention, first, we have to submit patient to diagnostic testing as indicated. Its rationale is tests are available depending on the cause of impaired tissue perfusion, angiograms, Doppler flow studies, segmental limb pressure management such as ankle brachial index or ABI, and vascular stress testing are examples of these tests. Second is a check for optimal fluid balance and administer IV fluids as order. The reason for this is for the patient to have fluid in fluid intake, maintains adequate filling pressures and optimizes cardiac output needed for tissue perfusion. The third intervention is to note urine output. It is to reduce renal perfusion may take place due to vascular occlusion. Fourth intervention is to maintain optimal cardiac output. For this measures adequate perfusion of vital organs. The fifth one is to consider the need for potential embolectomy hepatization. This facilitate perfusion when interference to blood flow expires or when perfusion has gone down to a serious level leading to ischemic stroke. The sixth is is to maintain oxygen therapy as ordered. It is to enhance myocardial perfusion. The seventh one is when patient experiences dizziness due to orthostatic hypotension when getting up. Educate methods to decrease dizziness, such as remaining seated for several minutes before standing, flexing feet upwards times while seated, rising slowly, sitting down immediately when feeling dizzy, and trying to have someone present when standing. This is for orthostatic hypotension results in temporary decreased cerebral perfusion. The eighth nursing intervention is uh, check for mental status, perform a neurological examination. This the reason for this, review trend level of consciousness or LOC, and possibility for increased ICP is helpful in deciding location, extent and development or resolution or central nervous system or CNS damage. The ninth is to assist with the position changes. This gently repositioning patient from a supine to sitting or standing position can reduce the risk for orthostatic and blood pressure changes. Older patients are more susceptible to such drops of pressure with the position changes. And the tenth one is to promote active or passive range of movement exercises. This exercise prevents venous stasis and further circulatory compromise. The 11th one is to monitor peripheral pulses and check for loss of pulses with bluish purple or black areas and extreme pain. These are symptoms for arterial obstruction that can result in loss of a limb if not immediately reversed. And the 12th one is if patient is encourage weight loss to decrease venous disease, because obesity is a risk factor for the development of chronic venous disease. And then for the evaluation, after 8 hours of nursing intervention, the patient manifests relief from any signs of enough tissue perfusion. Patient also verbalizes or demonstrates normal sensations and movement of a movement as appropriate. Patient's vital signs are stable and serum potassium level is controlled in acceptable range, reflect laboratory results, and patient also verbalize understanding of risk factors or condition therapy regimens, side effects of medications, and when to conduct or contact healthcare providers. And for the long-term evaluation, a patient no longer manifests signs of generalized muscle weaknesses, paralyzed to engage in exercise, like every day. Patient also engages in behaviors or actions to be able to improve tissue perfusion.
So we have here the last nursing diagnosis, which is imbalanced nutrition less than body requirements related to abdominal pain and cramping secondary to ascites and enlarged spleen. So for our subjective data, the patient verbalized, I don't eat a lot because my stomach is aching. I easily feel full after eating even a small amount. So for our objective data, we have here weight loss from 62 kilograms to 58 kilograms, the lack of appetite, have a, have a pain scale of 6 over 10, has a tender abdomen upon palpation, presence of fatigue, bloated abdomen, and has a abdominal girth of 49 inches. Girth. Caput medusa observed in the abdomen, absent bowel sounds upon auscultation, and has a flank dullness and percussion noted at the upper upper right quadrant of the abdomen. So for our planning for this short-term goals, after 8 hours of nursing intervention, the patient will gain knowledge about the importance of proper nutrition and participate in the implementation of nursing interventions, have understanding regarding disease condition and proper nutrition, demonstrate willingness in eating the right food, and for our long-term goals, we have here, after 1 month of nursing intervention, patient will demonstrate progressive weight gain toward the goal with appropriate normalization of laboratory values, experience no further signs of malnutrition. So for our nursing interventions, measure dietary like the calorie count. This provides important information about intake, needs, and deficiencies. Next is weight as indicated. Compare changes in fluid status, recent weight history, skin fold measurements. It may be difficult to use weight as a direct indicator of nutritional status in view of the or fold measurements are useful in assessing changes in muscle mass and subcutaneous fat reserves. Next is encourage patient to patient to eat, explain reasons for the types of diet. Feed patient if tiring easily or have SO assist patient. Include patient in meal planning to confirm preferences in food choices. This improved nutrition and diet is vital to recovery. Patient may eat better if the family is involved and preferred foods are included as much as possible. So next intervention, um, encourage patient to eat all meals including supplementary feedings. Patient may pick at food or eat only a few bites because of loss of interest in food or because of nausea, generalized weakness, and malaise. Next is give small frequent meals. Smaller meals to larger meals may be due to increased intra-abdominal pressure and ascites if present. And then provide substitute if allowed and avoid those containing ammonium. Salt substitutes enhance the flavor of food and aid in increasing appetite. Ammonia potentiates risk of encephalopathy. Next is restrict intake of caffeine, gas producing or spicy and excessively hot or cold foods. This aids in reducing gastric irritation and or diarrhea and abdominal discomfort that may deteriorate intake. Next is suggest soft foods avoiding roughage if indicated. Uh, this is because hemorrhage from esophageal varices may occur in advanced cirrhosis. Next is encourage frequent mouth care, especially before meals. A patient is prone to sore and bleeding gums and bad taste in the mouth, which contributes to anorexia. Next is promote undisturbed rest periods, especially before meals, because conserving energy reduces metabolic demands on the liver and promotes cellular regeneration. Next is recommend cessation of smoking, provide teaching on the possible down please, possible negative effects of smoking. Up. This is because it reduces excessive gastric stimulation and risk of irritation and may lead to bleeding. So next intervention is other laboratory studies such as serum glucose, prealbumin, and total protein ammonia because glucose may be decreased because of impaired gluconeogenesis, depleted glycogen stores, or inadequate intake. Protein may be low because of impaired metabolism, decreased hepatic synthesis, or loss into peritoneal cavity or ascites. Down, please. Next is maintain NPO status when indicated. Because initially the rest may be required in acutely ill patients to reduce demands on the liver. Down. Next is refer to dietitian to provide diet in high in calories and simple carbohydrates, low in fat and moderate high in protein, and limit sodium and fluid as necessary. Also provide liquid supplements as indicated. Because high calorie foods are desired in as much as patient intake is usually limited. Carbohydrates supply readily available energy and the fats are poorly absorbed because of liver dysfunction and may contribute to abdominal discomfort. Proteins are needed to improve circulation iron protein levels to reduce edema and to promote liver cell regeneration. Also note that protein and foods high in ammonia, such as gelatin, are restricted if ammonia level is elevated. So for our next nursing intervention is provide tube feedings, TPN lipids if indicated. So patient may this is because may to supplement diet or to provide nutrients when patient is too nauseated or anorexic to eat or when esophageal varices interfere with oral intake. So for our evaluation, after um, for our evaluation, short-term goals met. After 8 hours of nursing intervention, the patient verbalized full understanding about the importance of early nutrition and participated in the conduct of the nursing intervention. Next is demonstrated a good appetite and food interest. So for our the long-term goals met. After 1 month of nursing intervention, the patient gained weight and showed normal results from the laboratory, and there were no signs of malnutrition, such as lack of appetite or lack of down, lack of appetite or lack of food interest. So that would be all for the nursing care plans. Let us now proceed to the conclusion.
And finally, we are now down to the conclusion after the thorough researches conducted by my group mates and as well as me. We are almost through with the study of our patient. For our conclusion, acute gastrointestinal is a potentially life-threatening emergency that remains a common cause of admissions to the hospital. As future healthcare providers and advocates of our suffering from upper gastrointestinal bleeding related to esophageal varices, secondary to liver cirrhosis, it is our utmost responsibility to be knowledgeable enough of what the disease is truly all about in order to perform a much more effective and efficient nursing care and interventions that would address the management of this disease. We must always bear in mind that there are two essential steps for success. First is the management of acute bleeding and the prevention of rebleeding. It is also very essential to know how to educate our patient on the treatment and its prevention given the high recurrence rate to survive acute varicose hemorrhage should receive therapy to prevent occurrence before they are discharged from the hospital. Monitoring the patient is one of the most crucial roles of the student nurse. Vitals and oxygenation should be continuously monitored. Blood work should be followed to ensure that the patient is not anemic and developing renal or dysfunction. Close communication between the team is vital if outcomes are to be improved. And for our recommendation, upon going through a lot of research to supplement our study, we have seen that the mortality after the induced hemorrhage in patients with cir- cirrhosis has been reported to be as high as 50%. Considering the high mortality rate, treatment of these patients is usually complex and requires a team approach with defined stepwise management. Endoscopic therapy is a key aspect, but pharmacological management with vasopressor and antibiotic therapy treatments are also important components of successful patient care. As a student researcher, we recommend case studies that would allow constant research and clinical trials for the enhancement of the previous studies, which would knowledge and skills of the future healthcare professionals like us to become more competent in making judgment and compassionate in delivering patient care. These abilities would permit them to create and deliver a viable nursing care to their patients later on. And for our references, and I think that is it. And that concludes our case study. I hope we have learned something from it. It may not be free of flaws, but the soul and it has served its purpose. I hope we have learned something and have a great day ahead. God bless us all.